Welcome to Module 2, Using the Communication Function Classification System in Clinical Practice. After completing this module, you will be able to describe how classifications are made and differentiate the 5 CFCS levels, explain why classification is done in collaboration with families, understand how classifications are made based only on function and not considering a child's age or developmental stage, use the CFCS decision-making chart to classify children's communicative function accurately, and describe how CFCS classifications can support clinical thinking and decision-making. The universal version of the CFCS is free to download at cfcs.us and includes 4 pages to support the accurate classification of children's communicative function. After reviewing the CFCS materials, classifications can be made easily and accurately in under 5 minutes. The author suggests beginning with page 4, which includes a decision-making chart to help people determine which level most accurately represents a child's communication abilities. As an example, those wanting to classify a child's communication can begin at the top of this chart and ask themselves whether the child consistently and effectively alternates between sender and receiver roles with familiar partners. If the answer is no, the child is classified as either CFCS level 4 or 5. If the answer is yes, move to the box to the lower left and ask whether the child can consistently do this with unfamiliar communication partners as well. If the answer is no, the child is classified as level 3, effective sender and receiver with familiar partners. If the answer is yes, move to the box to the lower left and ask whether the child usually maintains a comfortable conversational pace with communication partners. If the answer is no, the child is classified as CFCS level 2, effective but slower paced sender and/or receiver with unfamiliar and familiar partners. If the answer is yes, the child is classified as level 1, effective sender and receiver with unfamiliar and familiar partners. Once a level is identified using the decision-making chart on page 4, the definition of that level on page 3 should be reviewed to confirm the child's CFCS classification. Page 3 includes complete descriptions of each CFCS level on the left side of the page, but also descriptions of the differences between each of the levels on the right side. The CFCS includes 5 functional levels for communication. Children in level 1 function best in terms of their communication, while children in level 5 function least well. Children in level 1 are effective senders and receivers with unfamiliar and familiar partners. This means they can communicate easily, both expressively and receptively, and at a comfortable pace with most partners, and that communication breakdowns are quickly repaired and don't interfere with the child's overall communication. Children in level 2 are effective but slower paced senders and/or receivers with unfamiliar and/or familiar partners. The difference between levels 1 and 2 is the pace of conversation. In level 1, the child communicates with little or no delay, but in level 2, the child needs extra time in order to understand or produce a message. An example of this includes children with disfluent speech or those using high-tech AAC systems who require additional time to convey their intended message. Children in level 3 are effective senders and receivers with familiar partners only. For these children, communication is not consistently effective with most unfamiliar partners, but is usually effective with familiar partners. An example includes children with speech sound disorders whose families understand most of their messages, but unfamiliar listeners have difficulty. Children in level 4 are inconsistent senders and/or receivers with familiar communication partners. These children are sometimes effective communicators with people who know them well. Examples include young children who don't yet consistently understand spoken language, and those who are late to talk who don't yet consistently produce spoken messages. Children in level 5 are seldom effective senders and receivers, even with familiar partners. These children have limited understanding of spoken messages, and communication is seldom effective, even with familiar partners like family members and teachers who know them well. Page 1 of the documentation provides additional details about the CFCS for those who need it. This includes explicit user instructions and definitions for terms like communication and comfortable pace that are used to make classifications. Additional information is also presented on page 2 for those who need it. This page includes clarifications about uses of the CFCS, and there is an area where the child's mode of communication can be recorded. In addition to being able to describe and differentiate the 5 CFCS levels, there are 3 things clinicians need to know in order to reliably and accurately classify children's communication using the CFCS. The first is that the CFCS is a classification tool and not an outcome measure. This means anyone can use it, including communication disorders assistants, therapy assistants, or family members. The second is that the CFCS should be completed in collaboration with families whenever possible. And third, children's communications should be classified based on current function. Chronological age and developmental stage should not be considered when making classifications. Why should clinicians complete the CFCS together with families? First, in the context of family-centered services, parents are the experts on their child and should be included in both assessment and treatment planning. Second, parents spend the most time with their child and observe him or her in multiple environments, making them best positioned to give an estimate of their child's everyday communication abilities. Speech-language pathologists make judgments about children's functional abilities during therapy sessions, but it may be difficult for them to estimate accurately how a child uses communication to function in other situations. Third, parents and clinicians may classify children's abilities slightly differently. More specifically, parents may place their child in higher levels of function. This may be because parents have the opportunity to observe their child in multiple naturalistic contexts. For those using the CFCS in research or program evaluation, consistently completing the CFCS in collaboration with parents will allow for the collection of more reliable data and a more accurate interpretation of therapy outcomes. For these reasons, it is recommended that clinicians complete the tool independently only when parents are unavailable. Why classify based on function? Speech-language pathologists typically complete assessments by considering a child's communication skills relative to their chronological age. For example, a 24-month-old child with a strong understanding of language, a vocabulary of 250 words, and multiple word combinations would be considered to have age-appropriate communication skills, because for a 2-year-old, they are performing very well. The CFCS is different. Using the CFCS, children are classified based only on how they function and not considering their chronological age, because the focus is on individual function and participation, and not on comparing children to their same age peers. A typically developing 2-year-old does not consistently express or understand messages accurately. Sometimes, even with familiar partners like mom and dad, there are still communication breakdowns. Traditionally, speech-language pathologists have used terms like mild, moderate, and severe to describe children's communication, but this method is focused on impairments and has never been shown to be reliable. What one clinician calls mild, another might call moderate, and what one calls moderate, another may call severe. It is also difficult to discern whether there are differences in children's abilities and how they function using these terms. For example, 2 children, both with severe speech sound disorder, may have very different functional abilities. Classification based on function can help establish a shared and consistent terminology to describe children's abilities. This terminology can help clinicians communicate more positively, effectively, and consistently with each other and with families. Consistent classification by levels of function also allows us to collect valid and reliable information to demonstrate the effectiveness and importance of our services to funding agencies. Next, 8 brief clinical scenarios are presented to provide opportunities to practice making classifications based only on a child's functional abilities. Please review the clinical scenarios one at a time. After reading the scenario and descriptions of the CFCS levels, write down your classification, and then compare your classification with the correct classification, which will pop up after 90 seconds. Scenario 1. A 48-month-old child with age-appropriate communication skills. This child should be classified as CFCS Level 1 because by the age of 4, typically developing children effectively send and receive messages independently. Scenario 2. A 60-month-old with childhood apraxia of speech. This child has receptive skills that are within normal limits, and the family understands most of what is said, but unfamiliar listeners have difficulty. This child should be classified as CFCS Level 3 because the child is able to effectively send and receive messages with family members, but not others. Scenario 3. A 36-month-old with developmental language difficulty that is primarily receptive. By parent report of performance at home, this child is able to follow familiar one-step directions, answer some basic WH questions, and has a restricted vocabulary. This child should be classified as CFCS Level 4. Due to the language difficulty, this child does not effectively receive messages from communication partners. Scenario 4. A 42-month-old child with language disorder associated with autism spectrum disorder. This child has difficulty in all areas of language and social communication, limited interaction with family and peers, and does not respond to questions or directions. This child should be classified as CFCS Level 5. This child rarely sends or receives messages, even with family members who know him well. Scenario 5. A 72-month-old child with cerebral palsy who is a nonverbal communicator. Expressive and receptive language are within normal limits, and this child communicates independently using an AAC system. This child should be classified as CFCS Level 2. The child is able to convey and understand messages, but because of the AAC system used to communicate, he needs more time to send messages. Scenario 6. A 28-month-old child who is late to talk with no receptive difficulties. This child should be classified as CFCS Level 4. A child who is late to talk does not consistently send messages that are understood, even with familiar partners like parents. Scenario 7. An 18-month-old child with age-appropriate communication skills. This child should be classified as CFCS Level 4. A typically developing 18-month-old does not consistently understand our messages or consistently convey their messages so that all possible communication partners understand. Scenario 8. A 48-month-old child with developmental language disorder that is characterized by difficulties with morphology and phonological awareness. Receptive skills are within normal limits. This child should be classified as CFCS Level 1. The child has some missing or inconsistent grammatical markers and struggles with phonological awareness, but his messages are consistently understood by most listeners. The CFCS may be useful for practice in many ways. It can help clinicians and clinical teams focus on children's abilities, regardless of the communication method used. It can support thinking about the whole child and their function and participation, not just their communication impairments. It can provide parents and professionals with a common language that is strengths-based, and it may be used to support intervention planning with respect to children's communicative function and participation. Next, some examples of how CFCS classifications may be useful for practice are presented. Intervention goals and techniques may vary by a child's CFCS level. For example, for children in CFCS Level 5, who are seldom effective senders or receivers even with people who know them well, clinicians may work to develop a dictionary of the child's communication behaviors that can be used to support partners in recognizing and responding to the child's attempts at communication. Clinicians may also work to increase the child's understanding and use of communicative functions to increase the rate with which they are able to communicate meaningfully. For children in CFCS Level 4, who are inconsistent senders and/or receivers even with familiar partners, clinicians can work to determine whether it is the child's speech, language, or social communication, or some combination of those, that is making the child inconsistent, and work to improve the consistency of communication. For children in CFCS Level 3, who are effective senders and receivers, but only with familiar partners, clinicians can work to identify the child's communication strengths and the ways that familiar partners are co-constructing meaning with the child. For example, the familiar partner typically has knowledge about the child that lets them correctly guess the conversational topics and messages at least part of the time. Clinicians can teach those methods to other communication partners, working towards effective communication with a range of partners. This may include the use of AAC to support the child in communicating successfully with more partners. For children in CFCS Level 2 who are effective but slower-paced communicators, clinicians may work to support the child in developing more effective and efficient methods of communicating. And for children in CFCS Level 1 who are effective senders and receivers with all partners, clinicians may work to address any residual communication issues that are impacting the child's function and participation. In summary, the CFCS has 5 distinct levels that describe a child's communicative function. Documentation to support clinicians in using the CFCS consistently is freely available online at cfcs.us. The CFCS is to be completed in collaboration with families whenever possible. This practice supports both family-centered services and the collection of reliable data. only communicative function is considered when classifying a child using the CFCS. Clinicians should not consider the child's chronological age when making classifications. This practice will help establish a shared, consistent, and strengths-focused terminology that clinicians can use to communicate with each other and with families more effectively and reliably. This shared terminology may also help teams focus on children's abilities, function, and participation and support intervention planning.